comments.
Okay, thanks, Andy. Thanks to the roundtable and Rob and Megan. That was a great setup for what I want to talk about today. And starting with Cigna, I spent about a decade with Cigna, a large health insurer. So much of the way I'm viewing the opportunity is through the eyes of the payer and the opportunities for payers to get involved beyond what they're currently doing through wellness programs and so forth, and really looking at strategic ways to bring money forward to prevention. So I left Cigna about 3 years ago to form Collective Health, and it was really around three questions. What matters to health? What can we do about it? And how can we pay for it? Not unlike some of the questions that have been raised today. And this is an educated group, so I'm not going to spend a lot of time on the first question, except to say we're in violent agreement. If you were to ask, well, conventional wisdom, let's say, holds that what matters to health is access to good quality, affordable health care. And while that's true, this educated group and lots of evidence shows that that is about a 10% impact on health over the life course. So then the question becomes, well, what really matters to health? And it's this very complex, intertwined constellation of factors, factors that are embedded in our communities, in our social, our economic fabrics, in our culture. It's the choices that we have and ultimately the choices that we make. And so it can get pretty complex, and there's lots of evidence around these sort of non-health care related determinants. And I think the question becomes, where do we invest when we know, for example, that education matters more to health than health care, has a larger impact on our health. We know that relationships, social connections with our friends, family, our support networks matter so much to health that they outweigh risk factors like obesity and community factors, and the Trust for America's Health, thank you, Jeff, and others have demonstrated that community factors and strategic investments in communities can return very favorable ROI in reductions in chronic disease. So how do we realign the health care financing system to begin to address these larger factors? And I think if we were czar, to use your analogy earlier today, David, and has been repeated, we might make different investment decisions because we're all really smart and we know what matters to health. The challenge is that the health financing system is so complex and it's very difficult to pry free the dollars that are being spent downstream on treatment of illness. However, we might look at investments in this health context and health behaviors, which account for somewhere around 90% of what really matters to health if you include biology and genetics in there as well. And yet we spend in this country, and we've talked about this a lot already, most of the $3 trillion or 2.7 trillion or whatever figure we use on health care, the traditional health care system, and very little on population-based prevention strategies that could avoid the need for that costly treatment in the first place. And as a result, our health outcomes are worse than other nations. So let's take a look at this opportunity through a different lens, which is an investment lens. If we were investors and we had that $3 trillion to spend, we might start with identifying and using data to help us identify, again, what really matters to health and where we could place strategic bets, along with treating illness and caring for people when they're in need. We could then start to extend our investments into longer-term prevention. And we would size up that investment opportunity, what the return might look like, see if there are opportunities perhaps to generate shorter-term returns that could be reinvested for ongoing impact and longer-term opportunities. And we would be really, really specific around those improvement efforts that have evidence. And I wholeheartedly agree with Rob that feasibility studies and the demonstration of evidence is critical to being smart about how we invest, and it's really a prerequisite for this new field of pay for success and impact investing. And then finally, we would also agreeing have sound evaluation methodologies that attribute our investments to the outcomes that we're seeing. And so health impact investing, here's one more chart, basically doing the same thing that Megan and Rob did, which is to explain who the players are in this. So in health specifically, the financial stakeholders here, the only thing I'll mention is that, sure, government is a big financial stakeholder. There's Medicaid and there's Medicare. But so are commercial health plans like Cigna, where I used to work. And we heard earlier about work that Cigna supported in Memphis because they have skin in the game. They're at risk for their HMO population. Well, so too are self-insured employers. Self-insured employers account for a big percentage of the healthcare dollars that are spent. And a self-insured employer, unlike one that's fully insured by a health plan, a self-insured employer is big enough that they're their own insurance company. So these are, Walmart and GM and Whirlpool, who I've worked with, and others, but they're actually getting to smaller employers as well. So employers are really important financial stakeholders and potential payers of outcomes for this impact investing world. On the investment side, I think just generally we're talking about three different groups of investors in impact investment. There are foundations that are now looking at not only philanthropic contributions and maybe providing that first layer of investment in the capital stack that allows other investors to come in, but also are looking at the potential for financial returns as well. There are high net worth individuals. Pritzker in Utah is an example of that, I think.
Mm-hmm. Oh, yeah.
And there are commercial investors like Goldman Sachs. On the service provider side, we're looking for those service providers that this isn't new. They've been doing this work for a long time, like Nurse Family Partnership, and they're looking for scale capital. And then finally, on the independent evaluators, I think we're looking for a few things here. We're looking for a way to, again, as Rob said, attribute the intervention to the result we're getting and the outcomes we're getting, including the cost savings. So for us, in the project that I'll talk about, we think that insurance claims data is a really important way of measuring impact on the financial side. So our evaluation methodology includes insurance actuaries who are taking in claims data to measure pre and post impact of the intervention. And we have a randomized control group so that we can see a comparison between our program group and our control group. Importantly, in this last phase around return, we think there are opportunities here again for, and I'm going to borrow a term from Rethink Health, and Janet Corrigan is here from Rethink Health, to use a progressive reinvestment strategy so that as we take short-term cost savings out of the system, a portion of those might go to pay back investors through shared savings agreements between the payers that are benefiting. So as we reduce Medicaid costs or as we reduce costs for Whirlpool, they're agreeing to pay back a portion of that to pay back the investors that provided the upfront capital. Medicaid and Whirlpool are keeping some of that savings for their bottom line. And a portion of that additional savings can be reinvested so that we can continually scale up programs that work and invest in these longer term opportunities. So what's required, we think, for health impact investing or pay for success? We need to know what's causing the illness in the first place. We need to know that we can do something about it. The intervention needs to be evidence-based. There needs to be good on-the-ground service providers, community-based organizations that have experience and a track record of success. There needs to be a net savings potential. So as Megan described, we need to be able to demonstrate that the cost of the intervention is far outweighed by the financial benefit. And we're really looking in health impact investing in the project that I'm going to describe in the financial impact. There's lots of other impacts that we're counting. But in terms of putting together a deal, and deals require line of sight to the financial impact and the repayment stream to investors. I talked about the different kinds of payers, and then it has to make sense financially from an investor standpoint. So there's lots of potential applications for health impact investing. I'm going to talk about childhood asthma. We heard about at-risk maternity. But there's lots of other opportunities, and there are groups that are looking at this. Social finance in Israel is looking at the opportunity to invest in preventing pre-diabetics from becoming diabetics. So there's evaluation of what it means to keep someone from becoming a full-fledged diabetic and avoiding those costs. And there are other opportunities, not just in physical health, but in mental health as well. And maybe far greater opportunities where those two are combined. My organization has looked a little bit at serious mental illness with multiple chronic conditions and the opportunity to help in a much more integrated way between physical, behavioral, and social/community support systems for that population. All right. Wholeheartedly, emphatically agree, violently agree with Rob about the importance of the feasibility study. So the project that I'm going to talk about, which is in Fresno, California, related to asthma, is being supported by the California Endowment. And the California Endowment believes in the opportunity of pay for success to address health at a community level and bring new sources of capital into that equation. To make that happen, the California Endowment, along with other foundations like Rockefeller Foundation and so forth, they're providing philanthropic contributions to support these kinds of feasibility studies. And we're going a little further than a feasibility study. We're actually doing a demonstration project where we're applying our approach to asthma that I'll describe in a moment. And we're actually taking in California, it's Medi-Cal claims data, so that we'll have a small sample of 200 children compared to our 200 in the control group, again, as a demonstration that there is financial impact to be had. And then we're looking for a pretty large scale-up opportunity. Unfortunately, in Fresno, there are a lot of kids who would benefit from the kind of intervention that we're doing with 200. We think there's probably somewhere around 16,000 that would match the profile of those who would benefit from this. So philanthropy as a bridge we think is important to validate that it works, to work through the value proposition, the business case financially, and also to work through all of the intricacies of the payer of outcomes. For the state of California's Medi-Cal program to be a payer of outcomes, we need to work through a number of hurdles that Rob has worked through successfully in Utah, or is in the process of working through, and what Massachusetts has worked through and what New York State has worked through. Somebody said, and I'm going to steal the quote, that impact investments aren't found, they're made. And they're made through this kind of important, often difficult, sometimes time-consuming work up front that really does require financial support. So let me give you this simple example of asthma in Fresno. Asthma is a big deal with kids in general. It's the #1 chronic condition among kids. In Fresno, it's a crisis. About 20% of the child population in Fresno has been diagnosed with asthma. We think the rates are actually much higher. They're significantly higher in the neighborhoods, and this is a place-based strategy that we're looking at. Maybe 30 or 40% of the kids in these neighborhoods have asthma diagnosis, and it's costly. We know that in Fresno County, about 20 people go to the emergency room, and about 3 are then hospitalized as an inpatient related to asthma. And it's about $35 million a year in the county. We also know we can do something about it. There are evidence-based approaches to helping children with severe, uncontrolled asthma. And when you have kids with severe, uncontrolled asthma, particularly in low-income neighborhoods, particularly in neighborhoods with substandard housing, there's a pretty good chance that there are environmental triggers inside the home that are causing those emergencies in the first place. Dust, mold, cockroach infestation, and we know we can do something about this. We can make changes in the home, pretty simple changes, and certainly less expensive than an emergency room visit, to improve air quality in the home. And we know from the evidence that when we do that, we dramatically bring down asthma-related emergencies for kids. In Boston, the study published in Pediatrics last year, a home-based approach reduced inpatient hospitalizations for kids by 80%. So it's a big deal. It's a big opportunity, and it's not widespread in implementation. So this is what we're doing in our phase 1, where we're demonstrating that the intervention works. We're measuring using Medi-Cal data and a randomized control trial what the cost savings are to payers, in this case to the state's Medi-Cal program. And we're developing our impact investment strategies, including bringing the investors to the table who would be willing to put the money forward to scale up the project. So I'm going to walk through what the scale-up might look like. If we take a pretty conservative estimate of reducing ER by 30% and inpatient hospitalizations by 50%, and we look at that potential universe of 16,000 kids, and we focus in on the top 10%. So we're looking at, can we help 1,600 kids through the intervention? Well, there's a net savings opportunity, net savings after paying for the cost of the intervention, of about $8 million. And it's going to be hard to see, and we don't have a lot of time, but these slides will be available to you. We think that's probably reducing healthcare spending per child per year of reducing it about almost $8,000. And after paying for the cost of the intervention, that's about a net savings opportunity, again, speaking strictly in financial terms here, of about $5,000 per child. So first phase, funded completely by the California Endowment. Second phase, we've engaged social finance as our social impact bond, pay for success intermediary in this. Really important, the service providers that we spent a lot of time in due diligence identifying up front include three partners. One, on the clinical side, we're partnered with a federally qualified health clinic, an FQHC. It's Clinica Sierra Vista. It's a pretty large network of FQHCs in California, and specifically serving the population that we want to help. We are now expanding the program, actually, in conversations with the large hospitals, because we think there are opportunities to enroll more children in the program, even in our phase one. But we started with Clinica Sierra Vista. On the community side, we've engaged Central California Asthma Collaborative. They have a methodology. They hire from local community, train and deploy community health workers who have really a magical way of engaging families in our communities. I've gone with them on their home visits. They're bilingual. We sit down in the living room, they sit down in the living room, have conversation with the parents. The child is usually there. It's a pretty extensive process they use to do the evaluations and the assessments, not only with the families, but then a physical assessment of the home. And one of the things we're doing in our intervention that isn't always done is we're providing a budget for home remediation. So we're paying not only for the community health workers in the home, but we're spending on average about $850 per home to fix leaky roofs, to prevent mold. We're removing molds. We're providing a HEPA vacuum cleaner. We're doing integrated pest management to get rid of the cockroaches. And we're providing green cleaning products to get rid of chemicals like bleach and so forth that trigger asthma emergencies. And our technical advisor is RAMP, Regional Asthma Management and Prevention. The return, we're measuring the return again, actuarial analysis of Medi-Cal claims data. We have both Medi-Cal plans in Fresno, which means we can cover, look across the entire Medi-Cal population in Fresno. So I think one of the challenges raised earlier is, well, what if you just have part of the payer or one payer involved? Here we've got both payers involved. Now we're not covering all of their children, but we're getting them at the table. And both payers have agreed to provide us data up front for our selection and on a quarterly basis to measure the impact of the intervention and the control group. Last part is we're engaging a third-party actuary at the end of our phase one to validate the study and the results that we've achieved. And you can't see it here too well, but to really look at that graph, which is here's what would have happened if we didn't intervene. Here's what the costs look like when we did intervene, and that savings opportunity there in the middle is repayment to investors and reinvestment in community, along with allowing Medi-Cal to save money. Okay, I'm going to leave you with one idea for a bigger example. It's actually more than an idea. It's a launch of a new organization called HICCUP. HICCUP is the Health Initiative Coordinating Council. One thing that's very interesting about HICCUP is that it is founded by an angel investor, Esther Dyson, who's a pretty well-known investor in the technology space and is now looking at opportunities to take an investor lens and look at the opportunities for improving community-wide health over a sustained period of time. So she's asked me to help her lead this initiative. We are launching this year to identify 5 communities that we'll work collaboratively with over 5 years, smaller communities, less than 100,000, and to take an investment approach to improving community health across the total population. What's
the prize?
To be named when we launch in 2 months. Yeah. This is still a little bit conceptual, but we're bringing partners and collaborators to the table. But the idea here is that impact investing, pay for success, it's one opportunity, it's one strategy. We heard from low-income investment fund, reinvestment fund. We heard from Kevin Barnett about community benefits dollars. There is a portfolio of financing opportunities that are available. And what's missing, I think, is a coordinated approach across these financing opportunities. And again, to borrow from Nancy and what Low-Income Investment Fund has done, we think this idea of a capital stacks approach can be really powerful in community health. So as we can get philanthropic contributions and public sector financing as the base of the stack, we think that we can increasingly bring in additional investments that might require a financial return, but would bring new sources of capital to communities. So we're building this idea, and we're looking for partners and communities to help us do that.
Thank you.